Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. On behalf of the Saudi Endodontic Society, we would like to welcome everyone to the new event of webinar lecture, which is one of the society goals to guarantee the continuous education mission during this challenging pandemic situation. Today, our speaker is Dr. Ryan Walsh, who will present a lecture titled Bioceramic in Dental Practice. Dr. Ryan got his bachelor degree of Art Biology Pre-Dentistry at the University of Iowa in 2007, 2011 Doctor of Dental Surgery from the University of Iowa, 2013 Certificate in Endodontic, Texas A&M University College of Dentistry, Dallas, 2016 Master of Science, Oral Biology, Texas A&M University College of Dentistry, Dallas. He is working at his private clinic, Advanced Endodontic of Texas Killer, since 2013. He is adjunct assistant professor at Texas A&M University College of Dentistry, Dallas, since 2015. Please join me in welcoming Dr. Ryan.
Good evening, everybody. Thank you so very much for having me. Special thanks to the Saudi Endo Society, the Pediatric Dental Society, and the Saudi Opera Society for coordinating this event. And again, thank you to Dr. Halawani and our folks over at New Smile, Mark Benford and Zina Hanoun, for coordinating this effort and getting everything in place. As was just mentioned, this has been a crazy past year and a crazy time when continuing education hasn't been the same as it has traditionally been, where we get together and collaborate. And so we're doing many things via Zoom these days. And it's nice to be able to get together with you guys and hopefully collaborate and come up with some thoughts and ideas here at the end of the lecture. So some overarching goals I want to start with are, first, I want to present some things that you've probably already learned, kind of reestablish, reiterate the foundations of what we're talking about in bioceramics. And then I'd like to present some things that are new, maybe that you haven't learned before, or some things you're unclear about. And then last but certainly not least, I'd like to stimulate some thoughts and have some discussion on how we can progress and continue to advance the field of dentistry and in particular bioceramics. So with that in mind, let's get things going. So a disclaimer, I am a consultant for Avalon Biomed. With that said, I've been using the Avalon or the new MTA products, the Avalon Biomed products clinically and in research interest for the past 10 years. So I think I'm very familiar with them. However, that's not just an exclusive. I don't only work with the Avalon Biomed products, or I haven't in the past. And so I think I have an unbiased approach coming into this with experience in many different areas of bioceramics. And a few publications. Again, most all of my publications have been centered around bioceramics. It's kind of a passion project of mine, and that I really enjoy these materials. I enjoy working with them and seeing the advancement over the past few years. And so the objectives for today, well, I'd like you to understand the role of bioceramics in endodontic treatment and understand the benefits of integrating them into your practice, whether it's an endodontic practice, whether it's a pediatric dental practice, or whether it's a general restorative practice. I think bioceramic materials have a lot of area to fit into all of those. And then become familiar with some currently available products. As you know, it seems like every week or every month we're getting bombarded with flyers or emails from product people saying there's new products for this, new products for that. And so let's kind of talk about some of the main players and kind of help categorize that in your mind so that you know where to go when you're looking for materials. And then be able to select the best bioceramic material that fits your clinical needs. I think that's just as important as knowing where to go to find the material as what material I need for this particular situation. And so we'll start by introducing bioceramics and bioactivity, move to the evolution of MTA, both the pros, cons, and where we're currently at, as well as the applications of bioceramic materials in endodontic, as well as pediatric and general practice. And then let's follow it up with some clinical cases. So allow me to nerd out for just a few minutes. Self-admittedly, I am a tooth nerd. Although I'm in private practice 4 days a week, I still find time to get down to the university and participate in some research studies and do table clinic type things as well. So indulge me for just a couple minutes while we revisit some of the basics. So let's start with bioceramics. What are bioceramics? Bioceramics compose a huge category of materials that are non-metal, non-resin. They're generally composed of zirconia, alumina, or silica. And within the large spectrum of bioceramics, there's a smaller area considered bioactive bioceramics. And these materials are going to be the MTA type tricalcium silicates we're going to talk about. They also include bioactive glasses and hydroxyapatite and things of that nature. But there is actually an ISO standard here that the materials are bioactive when they can form apatite in body fluids, including synthetic body fluid. And so that'll come into play as we discuss more materials later in the talk. And so what is a bioactive bioceramic? Again, kind of going from the broad to the more specific. It's a biocompatible material, again, composed of calcium silicate, alumina, or calcium phosphate, or hydroxyapatite that's intended to replace or help regenerate native tissues. And I think this is really important because regenerating tissues it seems to be the big hurdle in many areas of medicine and dentistry. And so I think we're at a day and age where we have products that are able to help us regenerate these native tissues. And so what are their uses? Well, they range anywhere from orthopedic surgeons placing hip implants, artificial hips, artificial knees and shoulders, to zirconia implants, all the way through bioactive glasses. But more specifically, when we focus on dental and endodontic uses, we're thinking of materials like Neo-MTA2 and BC Sealer, BC Putty. So bioceramics, MTA has been used in dentistry since the 1990s, back when Dr. Mahmoud Torbinejad first started placing Portland cement into teeth, and what stimulated his thought process there, I could not tell you. I think that's a very, very interesting approach to place cement into a tooth, but nonetheless, the bioactivity was there. And so over years, the ProRoot MTA patent expired. And so what happens when it expires? Well, now we have new MTAs. And with that, now everybody is able to invent or take a spin or progress off of the original material. And there are products produced all over the world. There's products produced in Korea, the US, Brazil, India. There's products produced everywhere. And I think that's fantastic. Every product has a little different advantage or a little different spin as far as how it can help or how it can be part of this dental community of bioceramics. So I like to personally think of bioceramics as 3 different classifications, I should say endodontic bioceramic materials. First, we start with the self-mix. For instance, the powder liquid. This is the traditional MTA, where you have a packet and some saline, or you have a packet and little compules that you have to mix together on a pad. The advantages here, they're multifunctional. You can use them as a putty. You can use them as potentially a sealer, especially some of the newer materials. And in our office, we often mix them with saline. I don't use the little compules if I don't have to. We just use saline, anesthesia, because we have it ready there for all of our patients. And I consider these materials kind of the jacks of all trades because they can do so many things. They're not pigeonholed into doing one particular duty. But the problem here is that, they are technique sensitive, and you do have to spend time to mix them. So manufacturers over time have come up with pre-mixed putties and pre-mixed sealers. And so I think these materials are also wonderful, but in my mind, I try to categorize them as 3 different materials: self-mix, pre-mixed putty, and pre-mixed sealer. And so here are some indications for those materials on the right. So this is the who of the who, what, where, when, why, and how. These are the major players in the game, especially the MTA-based bioactives. Starting kind of right in the middle, we have Avalon Biomed. I've already talked about NeoSealer Flow and NeoPutty and Neo-MTA2. Those are all under the Avalon Biomed name. Angelus has a couple products as well, Angelus MTA and BioC. But an interesting thing here is that Innovative Bioceramics out of Canada has a whole host of products. Most likely the one you're familiar with is FKG Total Fill. And although it's branded or labeled differently, it's really made at the same place, and it's identical to BC Sealer, iRoot, Edge Bioceramic. It's just what label they're putting on it at the time. So these are the major players that we'll talk about throughout the course of the lecture this morning, or this evening, excuse me, folks. And last, we have resin-based bioactive sealers. We will not spend as much time on these simply because I still think there's a lot of unknowns and research to be done here, but also they contain resin. So inherently in my mind, we have to think, is there some resin cytotoxicity? How much of the actual bioceramic material do they have in them when they have 30% resin and only 15% or so of the bioactive material? Is is the bioactive material able to get out into the tissues and actually stimulate, or is it going to be trapped inside this resin matrix? So I think there's a few things to be further investigated here, and not the main focus of today's talk. So talking a little bit about historical perceptions of bioceramics. Well, we know the desirable properties is that they're hydrophilic, and meaning they require water for setting, which is fantastic. We all work in the mouth. We're always fighting saliva. We're fighting dental tubule fluid. We're fighting pulp tissue. And for those pedodontists out there, you're fighting squiggly wobbly kids that are attached to the tooth that you're trying to work on. So we're always working in a moisture-rich environment. So another benefit here is that they release calcium hydroxide, which is fantastic. Calcium hydroxide has been used for years, both in the endodontic community as well as the pediatric and general community for pulp caps and things of that nature, and for intracanal medicament. And so if we can have a material that has a slow release of that over time, well, great. Now we're helping to stimulate those tissues and regenerate some of the apical tissues. And equally as importantly here, they're dimensionally stable compared to some of the earlier epoxy resin materials or some of the zinc oxyphosphate that may not have as much dimensional stability and may shrink over time. These bioceramic materials don't. There's actually a 0.02% expansion. So that's, again, another favorable property. But the things we've long heard about for being concerns are long setting time, washout, tubule penetration, and poor handling. So let's talk just a little bit more about those so that we can talk about where we're going with the newer materials. So long setting times. I guess in my mind, is this really a limitation or a drawback? If you think about it, the longer setting time may allow for prolonged release of calcium hydroxide. And most of our materials, if we're talking endodontics, are within a closed system. If we seal a root canal, I'm not really too worried about how long it takes to set. However, the question here, I think, isn't how long it will take to set, rather if it will set. We know this creates, or the reaction is from a hydration reaction, which requires moisture from the dentin tubules. So some of these materials that have a really, really long setting time, we're counting hours, probably even sometimes weeks, are they truly setting inside the canal space, or under our restorative material if we're doing pulp caps and things like, or pulpotomies and things like that. So ideally, we'd have somewhere kind of in the middle, maybe a shorter setting time so that we know we can get things to set inside the tooth without always having that question mark of when are things going to set. And I'm sure some of you have also gotten into the teeth doing a retreatment where you get in and you still see some sealer that is not completely set. And so to me, that just raises a question of where are we in this continuum of long setting time versus short setting time. And washout, that's historically been a problem, predominantly with the more traditional MTAs where you mix it with the saline water or the anesthetic, because there's nothing really to bind it and hold it together. However, the premix sealers, they're inherently anti-washout. And I'll show you just that in just a moment here. But the newer versions of the powder liquids contain an anti-washout gel. And here's a quick picture from the Formosa article showing that MTA anti-washout and MTA Plus and IRM amalgam have really, really low washout rates in both distilled water and Hank's balanced salt solution compared to PC, which is porcelain cement, or traditional MTA Angelus. They just don't have those binders to hold everything in place. And so, again, kind of thinking two classifications of the three materials here. On the left is the powder liquid mixed materials, and on the right is pre-mixed putty. So on the left, the top material is Neo MTA2, the middle is Pro Root, and then we have Biodentin. And so what we've done here, we've created little wells, and we place the material in the well. We let it set for 3 minutes and then used an air water syringe to rinse off any of the excess. And what you can see here is that Avalon Biomed, the Neo MTA2 mixed with the anti-washout gel had no loss. Conversely, as you move down, you see the Pro Root and the Biotentin have either half or almost all of the material gone. Now let's jump to the other side of the slide where we have the Neo MTA putty, we have EndoSequence Fast Set and Root Repair putty. And again, these would be FKG similar products. And you can see the same protocol was followed, the same rinse was followed, and less than 15% total loss in weight. So these pre-mixed materials are inherently anti-washout. And what does that mean? Well, that means that we should be able to bond more easily over them and not have to worry about when we etch and rinsing off the etch, all of our material coming out with it. And tubule penetration. I think this is an interesting topic because you can think of tubule penetration as adhesion. You can think of it as a bond. How far are we getting in there? This is a Torbenejad paper talking about removing the smear layer. And so I want to show that many of these products has varying particle sizes. Starting at the top, we have white pro root. So I like to show that as kind of a benchmark or a well-known accepted material here. And then we can look at the sizes of the others. And one common misconception is that some of these products by Innovative Bioceramics are nanoparticles. Well, sure, some contain nanoparticles. Nanoparticles are less than 0.1 microns, but that doesn't mean all the material is a nanoparticle. So we have the particles ranging in minimum size from 0.04, 0.05, 0.08, even 0.09. And those are all nanoparticles, and you see those in most of the materials. And then on the other hand, you see these giant particles on the max size. So in my opinion, I like to look at the median particle size and maybe even consider somewhere between the minimum and median as really what we're working with. Because we know the minimum particle size here is the minimum particles are probably most always radiopacifiers, the small metal ions that we use. So if we're basing all of our evidence of bioactivity saying the minimum particle size is the best thing, but that's all radiopacifier, well, how much of the actual bioceramic material are we getting into those tubules? So here's an enlarged version of the removed smear layer chart I just showed. The arrow's pointing to 5 microns. So some of these dentinal tubules are probably 3 microns, maybe some of them 6 or 7, just depending on how wide or oval they appear. And I wanted to show here's pro-root median, and then the little dot next to it is the pro-root minimum. And same with NEO, and same with BC, or the Innovative Bioceramic Materials, and the MTA Angelus. So my point here is that all of these materials have products that can fit into the dentinal tubules without issue. And that's important because we know that there's dentinal fluid that can help with the hydration reaction and create hydroxyapatite at that interface. Now, go to the other end of the spectrum, and here's pretty much the largest material, or excuse me, the largest particle for all of these. And this is probably going to form the bulk of the internal component, or the main body of what we're seeing on the radiograph. And is that a concern? Not in my mind, because we have these other smaller particles dispersed that can equally get into those tubules. Now, poor handling. I think we all know the classic materials handle, and I know the Avalon Biomed folks are going to cringe when I say wet sand, but I think this is a widely accepted term of how these materials behave. One of the main differences between the Pro Root and the Avalon Biomed product is that the Pro Root and some of the other similars are very grainy. When you mix it, it truly feels like you're mixing sand off the beach. Whereas Avalon Biomed, the particles are much smaller, so it's a very smooth mix. But I still maintain the wet sand mixture because of the vehicles we use for delivery. So even though the Neo MTA product is much smoother, I still pack it into an MTA block and insert that into the tooth. For me, that's the easiest way to approach some of these cases. I also have a MAP system. However, I prefer to use the MTA block. However, the new bioceramic materials, they're all pre-mixed. Well, there's no mixing involved. They go straight from the syringe into the tooth. And as you can see by the bottom picture, they hold form. So you can take it right from the tube, right from the jar, put it on a plugger, you can put it on a glick and introduce that right to the tooth. And I think that's a great advantage. They have incredible handling properties that have been developed and improved over the years. And last but not least, discoloration. And so here's a project that I was doing in residency. And I think all of you can see that one of these materials is not like the other. The second row there that's all white, that's an Innovative Bioceramics product. The other products were a couple prototype materials and some Pro Root MTAs. And you can see that they're vastly discolored compared to the other. And so let's look at a Maconiac paper. I think this demonstrates things well. And it shows these three examples showed discoloration in the furcation after 60 days. So this isn't talking about an anterior tooth, which I think you'd see more discoloration. It's talking about posterior teeth. And these are going to be gray MTA, white MTA, and MTA Angelus. Well, what's the similarity here? Well, they all contain bismuth oxide. And although the reformulation from gray MTA to white MTA reduced some of the iron or reduced some of the manganese particles, the main discolorant here is bismuth oxide. So let's compare that then to biodentine and endosequence root repair material, where there's no discoloration. And the common theme here is that there's zirconia or tantalum. So again, it's the radiopacifier bismuth oxide which causes discoloration. And this is a nice little paper by Mitu Kohli, where she shows she has teeth that are inherently naturally discolored, and that's totally fine. That's what we find in most of our patients. But importantly, the ones circled in orange, white MTA and gray MTA, look at the discoloration just over 6 months. I mean, that's marked discoloration compared to other more common sealers such as AH+ or biodentine. And I kind of excluded triple antibiotic paste here because that's a little outside the scope of our talk. And I'd be completely remiss if I didn't at least mention Josette Camilleri. And this is a quick case where she talks about discoloration with sodium hypochlorite, which I'm assuming most all of you use, endodontists use in one form or another. And this just shows that MTA plus with bismuth oxide discolors significantly more than Neo MTA plus or biodentine, which do not contain bismuth oxide. And so what do we do about this? Well, we just choose materials that don't have these materials in them. And I think more and more as we move on in our clinical and material development, we're going to find less and less bismuth oxide. Now, I will say this with a caveat that the manufacturers at Angelus have said that the Angelus MTA and the Fill Apex are probably transitioning away from the bismuth oxide. So I just wanted to throw that out there for any of the Angelus folks that, hey, they're making a transition. So let me show you a case. This was a case I did back in 2016. Kind of a run-of-the-mill root canal case. She was lost to recall for a long time, but then she showed up in my office just a couple weeks ago, and so I was eager to get a picture and see what was going on. And I think everybody here can appreciate that's nice healing. I mean, that's what we want when we do a root canal. And interestingly, this was done with Roth's sealer. And when I started private practice, we used AH+, and then we transitioned to Roth's. And why? Roth's is really cheap, and you can make a whole syringe of it and sit it out for a week and use it until it's gone. It's very similar to the Grossman sealer, but I really have to think what's going on at the apical tissues, what's going on in the lateral canals, what's going on with the tubular penetration. And I have to ask myself nowadays, is this the best that I can offer my patients? Yes, it healed, but are there cases where a bioceramic material would have maybe helped the case heal that otherwise wouldn't have? And according to Grossman's ideal sealer requirements, he asked for biocompatibility. But now we're at a bioactive phase in our endodontic life. And so I think we need to start helping to make that transition over to bioactivity. And so the next question obviously should then be, well, why do we need bioceramics? In a classic paper by Seltzer and Bender, they talk about if you clean a root canal, if you shape it and you obturate it, it should be successful. That's just not always the case. How many times do we see one of our beautiful root canals come back and the patient's still having trouble? Or how many times do you see a tooth that you're working on that's right next door to a root canal that's half filled, small apical size, and it just looks terrible? But that tissue is asymptomatic and is healed and has been like that for 20 years. So that's the cognitive dissonance there, that cleaning, shaping, and obturating does not always mean a successful root canal. So if we can use an advantage of having a bioceramic to help regenerate some of those pulpal or apical tissues, we're providing the highest level of care and best patient welfare. And again, our ultimate goal is regeneration of native tissues, not repair. Repair is easy. So the bioceramics here provide us the regenerative potential for both apical and pulpal tissue healing. And why not take use of any advantage you possibly have? So here's a quick review by Dr. Almeida talking about pre-mixed calcium silicate-based sealers compared to conventionals. And she found that the calcium silicate-based materials are similar or better than conventional endodontic sealers as observed in vivo and in vitro animal studies. So that's fantastic. That's showing that we're at least as good as the previous, probably better. And this study was done in 2017, so I would expect maybe even better now that we're 2021. And so how do we choose the right material? So I think all of us here, both endodontists, pedodontists, general dentists, can say that we've done probably several, if not all of these types of cases. Whether it's a root resorption or sealing or perforation healing or apexification, nonetheless, they're all things that we're going to run into. So I like to try to think that we use evidence-based dentistry, and that's kind of the culmination of all of this, where we have our scientific evidence, our clinical experience and our judgment, the particular clinical circumstance or case, and yes, patient preference is there, although I certainly hate to let patients dictate treatment, but they're part of this decision-making process. And so I think that's important to consider. And so overall, we're dental professionals. We're dental specialists. We should have an extensive armamentarium of products. Case selection, it might be achievable to treat a case with one product or with one product mixed different ways, or it may involve completely different products altogether. But those are things I like to think about when I'm trying to choose the right material, as well as bioactivity, dimensional stability, availability. Can I even get that material where I'm at? And of all of you guys in private practice, cost is always a factor to play. And I hate to say that things are based on financial needs, but on the same token, we're also running a business. So at some level, the cost and the patient welfare have to be the primary goals. And so I want to talk about the bioactivity. Again, I've talked about this a few times, but I think it's really important because we talk about at the very bottom line here, white ProRoot MTA has 76% of the bioactive hydraulic phases. Well, that's kind of been the gold standard for years. But again, these bottom materials here have a powder to gel or powder liquid mix. So yes, they're going to contain more of the bioactive ingredient. Now let's jump to the top half here, where we're talking about some of the newer materials. NeoSealer Flow, NeoPutty, the innovative bioceramics materials, where we're talking about 47% of the bioactive ingredient, and we're still getting terrific healing. So I think the manufacturers here have done a nice job of determining where the transition is between having radiopacifier and having hydraulic phases, because you can't have them both all at once. You know, me as an endodontist, I want a bright white canal on the radiograph, and I want it to heal. But on the same token, I don't want something that looks very anemic on the radiograph, even though it healed. That just conveys a different sense of quality to my general dentists. And so let's take a brief break here. We've been chatting for a little while. Let's take a brief break, and we'll come back and try to spend most of the rest of the time on clinical cases, which I think most of you are more interested in. I do want to play a quick video here from Avalon Biomed, since they are helping to put everything on today. And so after the video, we'll take just a couple minutes, and then we'll reconvene.
Hello, I'm Mark Binford, President of Avalon Biomed. I'd like to thank you for attending this presentation and thank Dr. Ryan Walsh for giving it. Since 2013, our goal is to manufacture the most versatile, affordable, and highest quality bioactive bioceramic materials for endodontic applications. Avalon Biomed is the only U.S. manufacturer of bioceramic MTA products. Our products include NeoSealer Flow, NeoPutty, and also NeoMTA2 and the original NeoMTA Plus, winners of Dental Advisor's Top and Preferred Product Award for the past 6 years. I'm excited to introduce the newest addition to our product line, Flow.
Excuse me, let me go back to the video here. It seems to be cutting out a little on us.
Mixed bioactive bioceramic is 100% resin-free. With NeoSealer Flow, you can do endo your way, whether it's warm vertical condensation, cold lateral condensation, or single cone obturation. We design NeoSealer Flow with more bioactive cement content than other leading brands and offer it at a more competitive price, making it the highest standard for bioceramic endodontic sealer in your patients. NeoSealer Flow is packaged with flow tips to reduce product waste by 40%, and our unique Flex Flow tips are also available, which reduce weight by 81% compared to conventional tips. We've also expanded our product line to include NeoPutty, a pre-mixed ceramic putty perfect for perforation repair and other endodontic microsurgeries. I'd especially like to thank Dr. Hassan Halawani and his team at Smile Agents for all they're doing in the kingdom to bring the most advanced and versatile bioceramic endodontic materials to you and to your patients. Thank you.
All right, is everybody back in action? Let's go ahead and pick up where we left off. So as we're going to transition into the clinical portion of the talk, I want to talk about a couple of clinical studies that I think are relevant and will interest you. The first one here is by Elizabeth Chabowski. She did a retrospective analysis of cases obturated with BC Sealer, again, the FKG equivalent here, in a single cone technique. And I'll talk about single cone versus warm vertical coming up. But here what they found was that over 300 teeth and on average over a 30-month recall, they found about 91% success. I mean, that's a fantastic success rate. I mean, that certainly fits into the category of if not improved upon some of our older healing studies, such as Ingman and Galabi-Vala, talking about overall healing success and the prognostic factors there. And so the fact that we can predictably get over 90%, that's 9 out of 10. If you tell your patients that 9 out of 10 root canals are going to be successful, I think they're going to be pleased with that outcome. And so in our office, we tried to reproduce this study using Neo-MTA2. And so in our case, not quite 300, but 265 teeth, an average follow-up time of a little over a year, and we found a success rate of 91%. So I would say that's very, very similar to using BC Sealer. However, an interesting thing with this study was that we didn't just limit it to single cone obturations. Because this is a self-mixed material, we have the ability to place the material directly into the canal, or we have the ability to use it as a sealer and obturate as a single cone. So for instance, on the top case here, I packed the distal canal with Neo-MTA2 mixed with anesthetic, and that entire canal is full of just Neo-MTA2. Whereas on the mesial canals, I use Neo-MTA2 and gutta-percha. And in the bottom case, Dr. Attar, my colleague, obturated both, or I guess all three roots, all three canals, both roots with the sealer version using gutta-percha. So combining all those techniques, we were still able to get 91% success. So I think that boasts well for a material where you can just vary the viscosity, change things just slightly, but use the same material for different clinical needs. So let's talk briefly about obturation techniques. I think this seems to be a hot topic no matter where you go. Are we talking about hybrid warm vertical? Are we talking about continuous wave? We're talking about lateral compaction, single cone. What's the best? And I think our studies really aren't going to ever come out and say single cone is by far and away the best material or the best obturation technique, or lateral condensation is the best. But I certainly think there are some studies when we're using these bioceramic materials that can help guide us to using a technique that is best suited for these. And so here's a study by Wong, and they were basically comparing iRoot, again, an innovative bioceramics, using single cone and warm vertical, and then AH+, our traditional epoxy with single cone and warm vertical. And what they found was that the iRoot can achieve comparable filling quality and better dental tubule penetration than our AH+. And so considering that bioactivity improved dental tubule penetration, maybe this is going to be advantageous for the sealing of the root canal systems. Moving ahead, Dr. DeLong, he was a co-resident of mine and did this nice little study on comparing bioceramic sealers in using single cone and using warm vertical or continuous wave obturation, and then checking the push-out strength. In other words, does heating the material alter the properties of the material that we're looking for? And so interestingly, what he found was that the continuous wave decreased the bond strength. So in other words, when you burn down, remove that gutta-percha, leaving the apical plug, and then backfill it, it has a decreased bond strength. So to me, between BC Sealer and MTA+, that shows that there was some event that happens, whether it's desiccating the sealer, whether it's heating and removing some of the organic solvents. It's hard to say what exactly caused that. But I think that raises a question in my mind that if we can do single cone, maybe better. But on the same token, talking about Greer McMichael's paper, they found that tricalcium siligates penetrated the tubules up to 2 millimeters. To me, 2 millimeters is a really long way from the central canal. And she found that continuous wave and single cones produced similar findings at both 1 and 5 millimeters from the apex. So this is again confirming that whether you use single cone or whether you use heated warm vertical or hybrid warm vertical, you're getting nice tubule penetration. However, I think we'd be very short-sighted and very foolish to think that you can operate every canal as a single cone. That's just not real. The canals are different morphologies. They're different shapes. They're broad, they're ribbon, they're figure 8 shaped. And so with that, I think we need to be open-minded and not be tunnel visioned that we can use hybrid warm vertical techniques and single cones together. And so today, in my opinion, single cone technique with our bioceramic sealers is a sealer-centric versus gutta-percha-centric obturation technique. I'm no longer burning all the way down, holding pressure to laterally push the gutta-percha and consequently the very thin layer of sealer out to the irregularities in the canal space. Here, I'm simply using a sealer that flows incredibly well, introducing my gutta-percha cone and using that as the hydraulic pressure and basically carrier to push that into the lateral canals. And I think you can see here, just comparing these two in a little block study we did not so long ago, there's almost equivalent flow between neosealar flow and endosequence, or the FKG. Now, granted, I understand that these lateral canals are much bigger than some normal lateral canals, but I guess we're not necessarily trying to replicate the canal size, we're trying to replicate the flow of the material. And so I think that's an important thing to mention here. Interestingly, immediately after I took off the tips, I took a picture of them, and that's the top picture that you see. Now, if you look at the content of the tip in the Brasseler product, or the top material, you can see there is a ton of sealer still left in there. I mean, I feel like I could obturate at least 2 extra canals, rather than the FlexFlow tip on the bottom, where you're not seeing a whole lot of extra sealer anywhere other than just right in the cannula. And so the folks at Avalon have developed these 2 tips. The ones that come standard in the kit are on the bottom left here, and they're the flex tip, and they reduce waste by 40%, and they're bendable. So not only can you introduce this much smaller tip deeper into the canal space, you're also reducing the amount of waste. And then the FlexFlow tips, which are also available, are designed for 81% less. I mean, there's the extra 2 or 3 canals that you can obturate just out of the material left in the syringe from the innovative Bioceramics products. And it has a flex tip, which again allows us to get around some of those curves that we would not have been able to get around before with our sealer. So talking again about obturation techniques, I think this raises a very interesting question, because Endosequence came out with high flow intentionally to be used with warm vertical technique, because they were having customer complaints about the sealer desiccating, the traditional endosequence sealer desiccating when used in warm vertical. Now, when it's a single cone, it doesn't matter a whole lot, right? I mean, if you look at time 0, I'm putting a cold cone into this, everything on the left looks like it should be good. Well, the study here was that they placed these materials on a hot plate at 200 C. And this is just 200 C. I don't know what you guys keep your system Bs at. I actually use 300 C. So they just slowly heated these up, and what you saw after 30 seconds is on the right. The top 2 materials, the innovative Bioceramics materials, are brown and they're porous. Conversely, the neosealar flow looks nearly identical to what it did previously. So what that's telling us is that the organic fillers and the organic solvent inside the BC products is evaporating faster because it hits a lower molecular weight, it evaporates at a lower temperature. Other than neosealar flow has heavier materials that evaporate at a higher temperature. So talking about single cone versus warm vertical, if I have to use a warm vertical technique for one of those broad canals, I think this helps me see that maybe neosealar flow has some advantage in this case, because it's not going to change properties as much as the endosequence. Now, with that said, I will be honest, I've used BC for hundreds of cases and never seen this brown effect occur. But nonetheless, I think this is just the end result of what's going on here. And even at a much earlier time and phase in this, the heated warm vertical, you're getting some of these micro changes. So here's a case I did 6 years ago now. This case was done by a local endodontist down the street. We know each other. He's a great guy. And the root canal, by all measures, length, density, and taper appears adequate. However, we're seeing this furcation breakdown. And she, in this particular patient, had a sinus tract right at the junction of the free gingival margin in the crown. So my concern here was, A, is there a root fracture developing? Is there a perforation? What's going on? So I elected to retreat this case with the patient, and she's like, I'm all in, let's check for a fracture. Well, what we didn't find was a fracture. What we did find was a strip perforation of the MB canal. And so as soon as I got in the upper right picture, starting to remove some gutta percha, I just saw this bleeding and immediately knew what the scenario was. And so what did we do? Well, we treated this tooth with Neo-MTA2 using a couple different variations. So I'll explain that here in just a moment, but really we used sealer on gutta percha cones for the apical third of the mesial canal and all of the distal canal. And then we packed it mixed with lidocaine from the furcation perforation all the way up to the chamber floor. And so here's at time 0. This is our post-operative film. Here's at 6 months, Here's that 1 year. We can see that furcation healing very well. And here's 2 years where we have a natural PDL, or very, very close to a natural PDL. Again, kind of harkening back to the regenerating the native tissues. This is terrific healing. Patient's asymptomatic. They're happy with the outcome. So walking through my technique of how I obturated, I started with what you're seeing in the upper right picture here. Mix the liquid with the anti-washout gel in about a 4-to-1 ratio so I can get it nice and thin and use it as a sealer. Because at this time, there were no pre-mixed Neo-MTA sealers. So I buttered my cones and placed it into the canals. And then we burned down to the level of the apical perforation. And so I was then able to remove that gutta percha cone, but that also left some of the sealer on the walls. And then what we did is we used an MTA block and packed that material down into the canal. Now again, I say wet sand here, but it's not a grainy, gritty wet sand. It's very, very smooth. And that's what I like about it to pack into these canals, is because I don't feel like I'm packing sand in a sandcastle, but you're literally condensing this material on top of it using a paper point to wick the moisture out, and you have a nice solid foundation of material that's not going anywhere. And then once I got up to the chamber floor, we etched, primed, and bonded and placed a final restoration for this lady. And so I don't think this would have been possible with materials of the past, certainly not with epoxy resins. It would probably not have been possible without a surgical intervention to try to place maybe a Fuji or some type of material like that. But I don't think you're going to see these types of healings without our bioceramics that we have today. And so let me show you a pulpotomy. And for my pediatric friends out there, no endodontists are not just pulp killers, contrary to popular belief. This is actually a case from my colleague, Dr. Attar. He saw this young person back in 2018. They had deep caries, but still quite a bit of sufficient tooth structure around the coronal aspect of the tooth. And in my opinion, and his at the time, no need to extract. So he removed the caries. And in our practice, we remove the caries. And once we get close to a pulp exposure, we've got all the peripheral caries removed. We switch to a brand new diamond burr to enter the chamber. So we're not introducing or trying to minimize the amount of bacteria introduced. He removed all the affected pulp. And the way we determine that is how much does it bleed? And if we get into the pulp, and sometimes you barely get in under the caries, and it's very hemostatic all on its own, we'll just do a partial pulpotomy. And we do those frequently as well. This just happens to be a nice case with a long follow-up. And so he placed it directly over the canal orifices, Neo-MTA2 again, mixed with the anti-washout gel to create a putty, placed it over the canal orifice. And so here's a 6-month. And you're starting to see some dentinal bridge. And compare to what we were just seeing, we're starting to see root development. So no, endodontists are not just pulp killers, we're pulp lovers. That's our job, is to be inside the tooth with the pulp, whether it's taking it out or whether it's helping it grow. And so as we move on and time progresses, you're seeing greater dentinal bridging and greater dentinal bridging and better root formation. And again, here we are 3 years down the road, and he has great root formation, great dentinal bridging. And so as an endodontist, I have to play devil's advocate and say, well, what if that tooth dies off now? Well, now we at least have nice full roots to do a root canal for. Yeah, we have a calcific bridge, but that's no problem with magnification and ultrasonics. But I think this is a really nice case showing a successful pulpotomy using the same material that we've just been talking about. And so here's a heroics case I want to show you, only because it's kind of fun to talk about. So really this came down to cold steel and sunshine, or extracting the tooth, versus using a bioceramic product to restore and to save this tooth. So I tried my very best to be the tooth Superman here. So this lady comes in. She comes with her husband. She actually won't let me take any preoperative radiographs because she's too worried about radiation, but she will allow me to take one cone beam CT to see where things are at. Oh, okay, I'll take what you'll give me. And all she knew is that she had absorption. Well, in reality, she had resorption, but she comes to us asking if she can save the tooth. She really doesn't want an implant. And as you can see from the sagittal view, there's already soft tissue growing up into the cingulum area. This resorption has been there for a while. Part of the tooth structure has chipped away. It's got soft tissue ingrowth. This is class 3, 4, probably 4 hither say, depending on where you want to draw the line of cervical resorption. And so I tell her at the first visit, I'm like, I would really like to help you save this tooth, but the chances here of saving this tooth are really, really poor. I think the most predictable option is to consider extraction with an implant replacement. And so that day she said, okay, sounds good. I gave her the referral to the oral surgeon. Well, she came back a few days later and said, I've weighed my options. I definitely do not want to have this extracted. I understand that it may only last me a month or a week. I want you to do the root canal. Okay, so we went down that path. And in the upper right, I've removed all the resorptive tissue that I could with an ultrasonic. Now there's no hemostatic agent in here. I just finished removing all of that material, or all those cells, and this is what I had. So from here, I pretty much had to take out all of the lingual wall and all the soft tissue of the lingual wall, used a little electrocautery, and then I built that back up with Fuji 9 Extra first. So I recreated her cingulum starting down near the osseous level. And then as you move to the bottom left page, or the bottom left picture, I used Neo-MTA2 mixed with lidocaine and packed that into the apical portion of the tooth, or apical portion of the canal. You can see that in the film, it's really broad and tapers down. So this is right where it starts to broaden out. And so here's our post-op. This is 100% Neo-MTA2 mixed with saline, and then to restore Fuji 9 Extra. So here we are in 2018. She comes back for a 6-month recall, all is good. And again, I either get to choose a CT or a film for her. So I chose the CT at 1 year, and look at this. We're having terrific healing. The osseous level is very similar to where it was before, probably slight regression, maybe a 0.5 to 1 millimeter, but she still has good root length given the situation. We have soft tissue adhering or supposedly adhering to the last ionomer with normal probing depths, and the apical tissues look terrific. We also do not see any further advancement of the resorption. And so here she is a couple of years down the road, completely asymptomatic, life is good. And so knock on wood for me, but for the time being, the tooth's still healing well and the patient is happy. So kind of a heroic case, but nonetheless showing that bioceramics maybe helped stop some of this resorption by increasing that pH up to about 12.5 and getting rid of some of those clastic cells that I know I left behind. And so I'm thrilled with this case, and so is she. But now let's get back into the heart and soul of endodontics and talk about a little bit more conventional cases. So here's a case that I saw, again, not so long ago, a year and a half maybe. Anterior abutment for a bridge. The big concern here was, is there a root fracture? My bridge has been there for 20 years. I really don't want to have to replace it. I don't have the finances. And again, walking through, she has some vertical bone loss on the mesial. She has what you call maybe a start of a wraparound lesion or a J-shaped lesion on the distal of that premolar. So I kind of walked her through and painted her a realistic prognosis that, yeah, I think we can maybe save this, but I think the likelihood of a fracture is high. And again, she agreed to our treatment, and so we've filled the root canal. In this case, we use NeoSealer Flow. So with NeoSealer Flow, I can get my sealer tip down to within 2 or 3 millimeters of the root apex. And to me, if we're talking about a sealer-centric technique, that's incredible. And I'll show you here in a little bit how that compares to some other sealer tips. But if I can get it to 2 or 3 millimeters, this is really replicating what we saw before. And this is the Neo-MTA block. I just reversed the image. So this is a mirror image of what we had just showed earlier. And this is 6 months down the road. So after I entered the tooth, I did not see a fracture. We completed the case. This is 6 months, and we're seeing remarkable healing. And here she is at a year. Bridge intact. Life is good. We're seeing near complete healing. I'm still continuing her on recall just because I think there's still a few question marks, but I don't think you can argue the amount of healing that you're seeing here. And so here's my internal case control. I had mentioned earlier that I've used a host of products throughout my endodontic career, whether it's AH+, whether it's Ross, whether it's BC Sealer or NeoSealer Flow. And so this is a case where this lady came in and she really had 2 issues. One, she had asymptomatic apical periodontitis on 14, but more importantly, she had irreversible pulpitis with symptomatic apical periodontitis on 15. And so, I inform her, here's what's going on. She said, due to finances, I can only complete 1. So obviously we address her chief complaint. So we do a root canal for her. I did this over 2 steps. So I initiated treatment on the 31st and then saw her back to complete on the 7th, just due to the hyperemic pulp. And this case was using BC. And so now let's flash forward ahead and we see her recall. Well, that's great healing, especially on a maxillary second molar. I found what I call 3.5 canals, where you find that groove in the coronal portion of MB, but it never develops into a true separate canal. It just joins. And then when she came back for a recall, I reminded her, I said, ma'am, we still have this other tooth that we need to consider retreating. There's still apical pathology there. And so the bottom left picture is the post-op of my retreatment of tooth 14. and then her 1-year recall on the bottom right of tooth 14, and then 2-year recall of 15. And so here, I used NeoSealer Flow for this case, in BC for the posterior tooth. And so both heals, that's fantastic. They're both nice bioceramic sealers, but EndoSequence has been the gold standard. But now we're having another material that can compete with that and say, is Neo equivalent to BC? So let me show you a quick video here about the washout, or how I clean up in the canal space. Now, this is not the case we just saw. However, I think it gives you a really good representation of how well NeoSealer Flow cleans. So I was treating 2 teeth on this lady, and all I'm doing is using water. Can you see how well that chamber cleaned up? Again, just water. And it all cleans up. Now I can go back and either remove a little bit more GP, or I can condense a little bit more. But just with water, I was able to remove all of the excess sealer. And so here's here's a case that I saw recently and really wanted to highlight this for this particular talk, because this isn't, for a tooth nerd like me, this is an exciting tooth. This is Radix centimolaris. It's got the really curvy distolingual root. And anytime I see these, I get excited because we know it's going to be a nice challenge. And so again, we treated this lady, symptomatic irreversible pulpitis, and we treated her over a couple visits. And so let me walk you through what I was doing in this particular case, because it's rather interesting. So let me jump ahead a little bit. So starting here, I'm injecting NeoSealer Flow into the mesiobuccal canal. I divided this tooth, and I'm treating both buccal canals with NeoSealer Flow, and I'm treating both lingual canals with C-Sealer, or again, the FKG equivalent. So look how thin that cannula is compared to my root, or compared to my prep. Again, here going into a canal that's a little bit more oval, I can place it right down 2 to 3 millimeters short of my working length, and you'll start to see it backflow. You start to see it fill the little fin that takes off toward the lingual here. Nice, clean, easy to use, and you can see that's very easy to see. So let's jump ahead. Give it a nice little pump, and then get ready to sear off. And because this canal at the orifice is larger than the gutter cone, sear a couple millimeters down. Not a true sear down, but maybe 2 or 3 millimeters into the orifice, just to make sure I get a nice tight fit. So then you'll see me condensing this. Let's jump ahead a little bit more. And what I will show you is that also, after I use that little bit of heat, you can still see there's wet sealer there. There's nothing caked on top. There's no round material, but you still see it's wet and pliable. Getting to the distal canal, here's where I used a more traditional warm vertical technique, what we call the high warm vertical. I'm not burning down necessarily to 3 meters, somewhere in the 5 meter range. And I did that because of the canal space here. Nice straight distal canal. I thought this was a place to use warm vertical, because then I can back and allow to control the sealer moving into the lateral fin. And so just a second, it jumps to high for us. Pause it so we stop getting the jump. You can see millimeter length. We're at 15 millimeters here. And so you can still see some of the wet sealer right over top of the gutta percha. Let me jump ahead and show you the BC comparison here. So here, this is the BC tip, or the FK tip. It's just larger. It doesn't fit quite as well into the canal space. Now, I only advocate recommending putting it into the middle half or a third even of the tooth. But one thing I noticed, I was having a lot of trouble getting it to bend into the mesiolingual canal because it's just a big tube of plastic. Again, there's nothing wrong with the sealer. I used it for years, but there's some inherent things that make the use of the Neo a little bit more user-friendly, if you will. So I did the same thing here, and this time I actually chose to use the Radix root, or the DL root, as my single cone, although it's irregular and larger in shape, it has that really tight apical curvature. So I elected to sear or use heated warm vertical for the ML, and then single cone for the DL. There we go. What I want to show is that you can see all of this dehydrated material. It looks like just kind of white chalk all around that canal orifice. And that is where we talk about the heat changing the properties of the material, is that it desiccated that material, because again, the low molecular weight fillers, they evaporate at a much lower temperature. So here I'm doing a little bit more traditional single cone, sear it right at the orifice, do a nice little compaction. Put a little edge there, shepherd that back in just a little bit. So interesting, look at the tip of that plugger. Rewind just a little bit. That is chalky material that you get when you plug or heat down BC sealer. Again, that sealer is changing its properties, whereas the NeoSealer flow did not do that. And so that's one thing I wanted to highlight here. But most, again, equally as importantly, I should say, is that right about this place here, 920, 940, we do a cleanup, right? So here, all I'm doing is going to spray it with water. Normally, when I was using BC sealer, I would use alcohol pellets and get inside and kind of flush around with alcohol pellets, and I'd use micro brushes to help get the BC out. But watch, I'm just going to use water, flush the chamber with water, and I think this gives us a good comparison between the buccal canals and the lingual canals. Whereas, as we dry my mirror, then you can see the BC canals, you still see a little bit of BC kind of clumped on the top there, and you still see that chalky halo around the ML canal. The BC doesn't come out all the way, whereas the NeoSealer flow, beautiful, it comes out very nicely. And why do I think that's important, or at least worth mentioning, is because now we have to talk about bonding, and we're bonding in a composite restoration there, and we want the ideal bonding that we can have. And so if we're having bioceramic material precluding us from bonding to the exposed collagen fibers, that may inhibit that. And so here's the rest of my case. I did a length film here, and then here are the canals sealed with hybrid warm vertical, and here the case is sealed with single cone. And so I think you'd be hard pressed to figure out if I hadn't told you that there were two different materials and two different techniques going on here. So moreover, there's similar flow characteristics, similar radiographic appearance, similar handling, and then Neo has a much better cleanup, in my opinion, than does BC. So that's kind of another fun case I wanted to share with y'all. And so I think the next logical question is retreating bioceramic sealers. And when I was in residency, this was the study that we talked about. It was actually from my residency program, talking about how hard it is to retreat bioceramic sealers with conventional rotary and hand files. Well, yes, I agree, but that's from 2011. But coming from the manufacturer's website, can NeoSealer flow be removed? Yes, it can, using some adjunct instrumentation. And so talking about another paper by Neil Akantan, they talked about the retreatability of MTA Philipex, MTA Plus, and AH Plus. Here they just did pre and post-op CTs, but they only used rotary instrumentation to get out the gutta percha. And so MTA Philipex came out, or it had less root canal filling remaining than MTA Plus, but MTA Philipex, compared to MTA Plus, it's a resin based, so much less bioceramic content. Again, do I think that can actually be bioactive in the same way that MTA Plus can? No, I don't. And I think this study actually kind of highlights that, because it's not forming as much mechanical interface of hydroxyapatite between the canal wall and the sealer. And so MTA Philipex came out easier than just MTA Plus, but again, only rotary instrumentation. The next study I think is an excellent study from Crozetta, and what they did is they used adjunctive techniques such as passive ultrasonic irrigation and ultrasonic tips, but they also did micro CTs. And so here, I think micro CTs are going to be a much better measure than just CBCTs. And so what they found is that lower values of remnant material were found for BC sealer compared to AH+, and that's the epoxy resin that we've all known and loved for years. And then not only was there just lower BC, but once they used the adjunctive irrigation technique, they found that there was less material after the ultrasonic tip yet. So we're able to remove the bioceramic sealer better than an epoxy sealer, and we're able to use that with remove it with an ultrasonic tip. And so here, I think, I don't know about you all, but I almost always use ultrasonic tips anyway for irrigation activation. And so I think if the question is, can it be retreated? Yes, it can be retreated. Can all of the material be removed? No, but it has never been able to be fully removed since we've been able to retreat root canals. So I think still bioceramics win out on this fight, if you will, because they have the biocompatibility, but they're also able to be retreated. So quickly, let's talk about root and surgery. For us endodontists, this is, in addition to doing root canals, this is the other most common thing we do. And this was a study that I did, got published in 18, but done back in 15, comparing Neo-MTA Plus and Quickset. Now, Quickset is a prototype calcium aluminate, but I want you to focus on the Neo-MTA Plus. And so we did these in canine models. We obturated them all with Neo-MTA Plus mixed with lidocaine, packed the distal canal, and then resected it, gave the dogs 4 months, sacrificed the dogs, and then did histology. And these histology slides are of the same view, just the one on the right is much more magnified. And what you can see is that you actually get cementum directly deposited on the Neo-MTA surface. Directly deposited. There's no fibrous encapsulation. Like Wolfson talks about fibrously encapsulating materials. This is not that. This is bioactivity stimulating reformation of cementum and reformation of periodontal ligament adjacent to intact solid alveolar bone. I mean, in my mind, what better healing do you want? This is our ultimate goal in every single case. And so let me show you a surgical case. Again, this is my case from my office, and this lady came to me with discomfort in the upper right. She had a sinus tract, but root canal was just done not so long ago, and nice root canal, all things considered, but that MB is pretty off-centered. So according to Hain and Pink, there's most likely an MB2 canal hiding in there. And so as we open it up, sure enough, there was. So we clean shape and obturate, just like Seltzer and Bender. So this tooth should have healed, right? Well, not exactly. She came back 3 months later, the lesion looks bigger, and she has a sinus tract. So at this point, we take a CT. Is there any evidence of fracture? I don't believe so based on this. We're not seeing any lateral extension other than surrounding the MB and the DB roots. The palatal roots seem to be spared. All the canals were filled adequately. So what did we do? Well, we decided to perform apical surgery, and we put Neo-MTA into the tooth. So we resected DB and MB, and we did 3 retrofills. And here's our post-op. 3 nice little retrofills. Yeah, I think DB could have been a little bit deeper, but that's neither here nor there. And so here we were in 2019. Submitted, it was a periapical granuloma, so that's always a good finding. And let me show you just a little bit of this as well. I had this nicely recorded for us. Let's go to here. And here's our RetroPep. We like to use the KISS tips. And on RetroPep MB there, and then you can see some better purchase coming out of MB and MB2, just distal or just internal, and then DB you see. So here we're just about finished. Good, here's our finished RetroPep. I'm going to spend a little time now just measuring, making sure I'm getting 3 millimeters. And we're 2 maybe there, and then we're getting a little bit better, 3 toward the front, excuse me. And so then I spent some time removing the rest of the granuloma tissue, and let's move up to our fill. So here, I like to put racelets, those are epi-soaked cotton pellets, and that helps control hemostasis, but it also helps prevent material from falling back into the crypt. And so this is Neo Putty. And you saw how nicely I had it formed as a cone on the tip of the hollow and back. That's what I like to use. And I'm just placing it into the canals. And as an endodontist, I'm going to use a lot of material to make sure I have a nice dense root fill. So you'll see me go back a couple times here. Again, putting it into MB and MB2. And it's still nice and workable. And that's what I like about this, is that I can add extra increments. Sometimes I'll go back with the plugger and just tamp it down to make sure I have it all the way at the root tip. But again, another little cone placed to the root canal space. So that patient, after treatment, she was lost to recall. I didn't see her back for a long time. And because I knew I was giving this presentation, I gave her a call and said, hey, will you come back? I'd love to check this out. And last month she did. And what do we find? But we find really, really nice healing here. We find that the retrofills were sufficient, they're intact. We find nice apical bone, but that's not enough. We had a CT to start with. We need a CT to compare. And so here what we're seeing on the MB root, see that trabecular bone. We're not seeing fibrous encapsulation. We're seeing the trabecular bone directly deposited on top of those retrofills. Nice bone density, although you can tell in the sagittal view again that there might be a little bit of an apical, quote unquote, apical scar or delineation of the difference in trabecular pattern, but that's a terrific healing result. And if you noticed on the first slide, there was sinusitis in the maxillary sinus, which is no longer there. So again, nice healing results. So let's just do a brief recap. To understand the role of bioceramics, they provide regenerative potential for apical and pulpal tissues. They're the most bioactive and biocompatible materials that we have, and they create the best seal or interface between the tooth and the material. In understanding the benefits, it's a good business decision, but it's also a good patient welfare decision. And when it all comes down to it, serving our patients is what we're here for. And so becoming familiar with currently available techniques, well, I've talked a lot about neosealar flow and neo-MTA putty, but also the innovative bioceramics, the Angelus products, Septodont. All of those are some of the key players in this new forefront. And then be able to select the best bioceramic material for use, thinking about biocompatibility, ease of use, availability to you, cost, and dimensional stability. And for me, Endo our way at our practice, nowadays we're using exclusive Neo products. Again, in the past, I've done a lot of BC Sealer, I've done a lot of Roths and AH+, but Neo has some distinct characteristics such as easy washout. I only need 3 materials to complete all of these cases. It's easy to clean up. I can use it for such a variety of things. Endo our way is Neo. So the Neo family has a higher concentration or higher content of bioactive ingredient. It's more cost effective and multiple products for every endodontic need, which again, to me is important. And the familiar flow with easy cleanup and lower waste tips. And so my last question to you is, I show you how I do Endo my way. How do you Endo your way? And with that, thank you for your attention very much. These are my colleagues and myself here at our private practice. And again, thank you so much for your attention.
Thank you so much, Dr. Ryan, for this informative lecture. And yes, we are a pulp lover. and now we'll open for questions. We have a couple of questions. The first question is from Mark. Could you discuss Philippix compared to premix and powder liquid bioceramic products?
Sure. Thanks for the question, Mark. And I touched on this just a couple times, but let me get you the video so you can actually see me. There we go. The Philippix is again, it's a resin-based material. And so I think that's a concern for a few reasons, is that, yeah, it's easy to use, but we still have resin present. So does the resin trap the bioceramic products? Is it able to get in contact with the surrounding tissues? So is it going to be bioactive the way that we want it to be? And also, it has such a much lower percentage of the bioactive ingredient that I think the answer is questionable. Now, yesterday I was just at a CE course, continuing education course for bioceramics in the restorative world. And the restorative folks think very highly of this, but it's interesting, they don't know about the endodontic materials. And so I was trying to introduce them to a few of the materials I talked about today, which have some improved qualities that I think they'll really enjoy, including having a higher concentration of the bioactive ingredient. I hope that answered your question, Mark.
Second question is from Fahad. In case of extrusion, of the Neo sealer, what will happen?
Sure. I mean, it has happened to me. I will not sugarcoat that. Yes, it certainly happened. And we have not had any adverse effects from it. In other words, even if there's slight sealer extrusion, there's some schools of thought that actually recommend that, and that's fine. But I'm not talking about that. I'm talking about a lot of sealer extrusion. And likely what will happen is that over time, the body will form natural bone around that because it will still stimulate hydroxyapatite formation. I have yet to see any case come back where there's been pathology or fibrous encapsulation of that material. And so I have not histologically evaluated these teeth. So hold me to that. Don't hold me to that. But there's been no adverse impact. The patient has not had any increased postoperative pain nor lingering symptoms. It's just a finding now. And so it's something that I let them know about. We'll continue to watch, but I have yet to have any adverse effects for that.
Okay. Doctor, why the Neo has more easy for a cleanup? Why it's even easy to wash out?
Yeah, great question. And so it has to do with the amount of organic fillers, or excuse me, not the amount, the type of organic fillers and the mixture of the hydrophilic phases or bioactive phases in the cement. So it's a unique composition. So each one of these sealers has a unique composition that's proprietary to that manufacturer. And so it has to do with how they're adding those organic fillers and solvents. And I guess I wanted to address washout too, that it's not washing out down below the canal orifice. It's like a controlled washout where it only washes out in the chamber. Because if I go back in and do a little cleanup of some of that gutta percha that's just a little over the orifice, I still have wet sealer all the way around it. So it just washes off the initial phase or the initial kind of mess, if you will, in the chamber, but does not impact any of the sealer down into the canals, which I think is an important point that I wanted to also emphasize.
Okay. On the behalf of the Saudi Endodontic Society, thank you so much, Doctor, for this lecture. Thank you for having you with us today. And thank you all for attending this event today. See you inshallah in the next event. كل عام وانتم بخير. شهر مبارك عليكم. We're having Ramadan after 2 days. Thank you so much, Doctor.
And thank you so much. And one last comment here is that if any of you guys have any questions or concerns, feel free to email me. But also the folks at Avalon Biomed rather, have put together a compilation of the research done on these materials in an abstract format. They have every research article published about this. So if it's something you'd like to learn more about or read about, reach out to Dr. Halawani, myself, or Mark Binford, and we'd be happy to get that for you. And again, thank you, Doctor. So much.
Thank you, Doctor. And if there's any more questions, we will forward it to you by email.
Sounds wonderful.
Thank you so much. Have a nice day. Thank you.